Dr. Khan, for a wonderful presentation. I have a question about something that you remarked on at the ASIF meeting, which was that in China, there's a subset, I think you said, of the HLA-B27 gene. I think you said it's 27.4 or something, which causes more severe disease in the Chinese. It strikes me, though, that smoking might also explain why the disease is very severe in China. Could you just elaborate on those two things?
Yeah. HLA-B27 was thought to be a classic example of a protein molecule. It turned out it comes with 114 flavors. In other words, there are 114 different types of HLA-B27. The most common subtype is called HLA-B2705, which is so-called the mother molecule. And then over the millennia, changes have happened with evolution so that if there is one amino acid change, that would be a different subtype, and so on. So out of 114 subtypes that are currently known, only 5 or 6 are relatively common. Others are very rare. So I told you HLA-B2705 is widely distributed in the world, although the prevalence varies in various populations. B2704 is the other subtype that is common, but predominantly in Chinese. In Chinese, about 50% of the population has B2705, and the remaining population has B2704. It turned out that those who have HLA-B2704 subtype, they are more prone to getting the disease than those who have B2705. And so in China, they have very severe AS, also very common, far more common than rheumatoid arthritis. And they do smoke. And so it could be that their excessive smoking as well as their genetic background leads to much more severe disease. And there is another subtype called B2706, which is predominantly seen among Indonesian population, Southeast Asian population. That subtype is disease neutral. It is not disease associated. But in USA or rest of the world, you don't need subtyping because the subtypes that are present in rest of the world, with one exception, in Italy there's an island where there's another subtype, but all the subtypes present that have been studied thus far are disease associated. But if you are a rheumatologist in Indonesia, where Indonesian population has B2706 quite frequently, that subtype is not disease associated. So there you may do subtyping, but not otherwise. Yeah. I think...
Thank you again for your wonderful presentation. I was curious if you found that there's a relationship between laxity in the ligaments to spondylosing ankylosing.
No, there is no evidence.
Thank you.
You're welcome. So any other person? I think you can go to the microphone. Unfortunately, there's only one microphone.
I'm wondering about with the HLA B27. Is that the only marker for?
No. This is the best marker we have, but there is need for better biomarkers because a lot of patients they get the disease, but they don't have B27. In fact, 80% of Europeans or people of European descent do have B27 when they have AS. 20% of AS patients in Europe do not have B27. African Americans in this country, 50% of African American patients with ankylosing spondylitis do not have B27. So it's not a diagnostic test, okay? So it is the best biomarker we have, but it's not perfect. And also, as I told you earlier, 95% of people with B27 in the general population don't get the disease. So you can't do B27 testing without a proper reasoning, because if patient has fibromyalgia and you do B27, 8% of people of European descent possess B27. So the 8% chance fibromyalgia person would have inherited B27. Okay, so B27 is a worldwide gene distributed among various populations, but the prevalence of this gene in various populations varies quite a bit. In Europe, up to 8%, but if you are living in northern part of Norway or Sweden, or there is 12% prevalence. Among the natives of Alaska, Eskimos, up to 40%, 25 to 40% can have B27. In the general population, the more gene you have in the population, the more prevalent the disease will be. The highest prevalence is in Canada among the natives of the island of British Columbia. Every other Haida native has B27. So years ago, a study was done where 6% of the population suffers from ankylosing spondylitis. Okay? So that's a lengthy answer to the question. Among Sephardic Jews and among Arabs and also Mediterranean countries, only 75% of the patients with this disease have B27. Okay, so you need to consider the ethnic background of the patient when you do the test and how to interpret the clinical meaning of that test in that particular patient. For example, in African American patient, if the test is negative, it doesn't help one way or the other. But if it is positive, it is very highly suggestive that this is the disease. Yeah.
You had referenced the connection to the gut component. What treatments are recommended in regard to
for the gut
yes.
inflammation? Well, TNF inhibitors are very effective, except one of them to treat both conditions. So etanercept is the exception. It doesn't work for treating Crohn's disease or colitis, but all the other inhibitors, all the other TNF inhibitors have benefits, would benefit both conditions. While secukinumab, that targets interleukin-17, it doesn't heal inflammatory bowel disease. So you will not use this particular protein molecule to treat the patients who have two diseases together. But psoriasis, those who have ankylosing spondylitis, psoriasis, both illnesses respond to all the TNF inhibitors and also secukinumab, although the efficacy varies. For example, secukinumab would be very effective for psoriasis as well, while etanercept is not as effective as also some of the monoclonal TNF inhibitors are very effective for psoriasis.
Thank you. I have one more question. Calcium loss in relationship to disease. Is there any studies on the calcium loss in the body with that?
Yeah, a lot of studies have shown that these cytokines that cause inflammation, they also lead to bone loss. So young individuals, when you do their study their bone density, many of these young people with the illness for only few years, they already have net loss of bone. So osteoporosis is a component that had been neglected in the past, and when you treat them effectively, then their bone loss decreases. But what is lost is lost. So, yeah.
Hi, I was just curious about your comment or the notation on the effects of smoking and amplifying or exponentially increasing some of the effects once you have bone spurs. Is that because of the act itself? Is it because of the additives in most normal cigarettes? Does that also go on to vaping, to nicotine patches, to Nicorette gum? Is it just the nicotine itself? I'm just wondering a little bit more context.
Yeah. I think if somebody can't quit smoking, at least they can try the patch if it is pure nicotine, because the smoke has so many things, so many molecules, and it hasn't been figured out which one of those are the target.
Thank you, Dr. Khan. Are you receiving new patients?
You know, I am 74 years young, so the university gave me emeritus status. When people think emeritus, that means I am ready to prepare for the next word. So I'm still active, but with the emeritus status, I am so happy. I can go anywhere I want to be a poster child for ankylosing spondylitis, to speak to patients as well as to healthcare providers, and the university lets me do that. I can leave anytime, as long as I want. My hospital, if I claim from them my salary, then the county system wouldn't allow me to get even a pen or a penny from pharmaceutical company. So now I'm able to make a little bit more money than my salary by getting the honoraria that allows me to walk. So I came from China just 2 nights ago. And so I am seeing patients, but what has happened, I told my hospital, don't pay me any salary so that I'm not bound to be at your service all the time. So provide free service. I have been training my colleague. She sees the patient in my presence. She has to type the notes, and she makes the money at my expense. So yes, I do see patients, but whenever I am in town.
All right. My real question is about triggers.
Yeah.
What causes inflammation triggers?
Yeah.
I will have triggers of different types, I think, stress, sometimes other things. But what have you found from your studies over your career, 40-year career, about triggers that cause this inflammation and pain?
Well, I've been a patient for I've been a physician for only 53 years. And I can tell you, I don't use personal anecdotes, just I will share information based on what is scientifically true. But there are many patients who think that certain things trigger their symptom, and you can't refute their assessment. So at the moment, all we know is that for some reason, the gut becomes leaky. It tends to not protect completely from the bacterial products or bacteria that may invade into the gut lining or release certain proteins that access the bloodstream, and then it will lead to activation of certain cells that are present in the entheses, and there's an animal model for that, and that enthesitis then triggers more amplification of inflammation. So to begin with, interleukin 23 in the gut may be the culprit, that when it gets released, then there are cells that have receptor for interleukin 23 in the entheses, and they get activated. Then these cells release not only TNF alpha or TNF molecule, and also interleukin 17. So but there are other cytokines that are released one of them was called interleukin 22. That was suggested to be the factor that leads to bony fusion, but that has been not confirmed in human studies, while animal data suggested. So there must be interleukin 17, TNF inhibitors play a role in inflammation, but there must be additional cytokines that stimulate osteoblasts, the cells that make new bone, and they then form new bone, bridging the vertebral bodies and fusing it ultimately. So the aim is to stop inflammation. That is helpful in slowing down osteoblasts and bony bridging, but one would hope to have a molecule that one will hope to know what is the mechanism of new bone formation so that one could directly target that site as well. So a lot of work is going on in this regard, but the triggers we don't know. It's not Klebsiella in the gut, okay? There is this website called kickass.org. They keep saying Klebsiella, don't eat bread, and so on. That's nonsense. There is a trigger in the gut, and already we know the gut microbiome, the bacteria that live with us, there is a difference among patients versus controls. So there is alteration of gut microbiome that is playing a role in this disease. But we can't say which bacteria are the culprit, okay? And also HLA-B27 positive people have a slightly different gut microbiome than those who don't have this gene. So much more needs to be uncovered, and there's a lot of focus nowadays on gut microbiome. And alteration of the gut microbiome plays a role in many diseases, in addition to ankylosing spondylitis. Yes?
Hi, Dr. Khan.
Hi.
Thank you so much for being here with us today. I'm newly diagnosed, and my primary issue is in the sacroiliac joints. And I was wondering if you could just speak a little bit to the prevalence of sacroiliitis in both, spondyloarthritis and then the development of ankylosing spondylitis. I know you talked about peripheral versus axial disease, and I'm just curious, do all patients have some involvement of the SI joints? And if you could just speak to that.
Yeah, axial involvement is best exemplified by sacroiliitis. So sacroiliac joints are part of the axial skeleton. And the hip joints and shoulder joints are also considered root joints. So when we talk about axial spondyloarthritis, that would be patients who may have only sacroiliitis, or sacroiliitis with lumbar spine fusion, or those who can fuse up the whole spine, including the neck, or they have hip joint involvement and shoulder joint involvement. Hip joint more severe than shoulder. So that is classical axial spondyloarthritis. Some patients may rarely have knee swelling and so on, but that may not be persistent. Some may have Achilles tendonitis, painful heel. But then in your case, you have sacroiliitis, which is the hallmark of ankylosing spondylitis. But the old definition of ankylosing spondylitis will be very scary for you. You think you will fuse up like that, but chances are that you may not. We don't know what percentage of people the disease stays limited to the SI joint. There is some guess that maybe 25% of patients with your illness will stay at SI joint, not the spine, while 75% will progress. But if you have those risk factors I mentioned, then you will more likely progress to involve the whole spine. Okay?
Thank you, Dr. Khan. You spoke a little bit about AS in women and how the progression of the disease is a little bit slower. Are there any changes to the pain management recommendations for women or women with pregnancy?
Yeah, the question about pregnancy, there is a very nice article written in the web page of Spondylitis Association of America. You should read it because women have to, many of them are childbearing age, and it comes to whether to continue treatment during pregnancy and so on. And so please do read it. It's one of the people here can tell you that particular news feed or Rich can tell you, he's sitting there in the back. So I won't have time to elaborate. But treatment, diagnostic process is similar between males and females, but the management can be different based on the comorbidities as well as the pregnancy. Okay?
Thank you, Dr. Khan. We have two questions that have come in through our social channels. The first coming from Jim via Facebook. And his question is, based on your experience, do many patients discontinue NSAIDs after starting TNF inhibitors, or do they continue both?
Yeah. So there is tendency for patients to stop taking NSAIDs because they become pain-free. Recent data suggests that if there are no contraindications, it would be wise for them to continue because recent study from California indicates that those patients who were on TNF inhibitors and continued to take NSAIDs, the slowing down of axillary progression was observed more often among them than those who stopped taking NSAIDs. But if the NSAIDs cause problems, if there are contraindications, then obviously the patient would stop stop NSAIDs. Okay, so continuation, co-therapy management will be better than just switching off NSAID therapy because the patients are asymptomatic due to TNF inhibitors.
Okay, thank you. And our second question comes from Juanita via Twitter. She says, can you advise regarding smoking if the risk is the same with cigarette smoking and nicotine through vaporizers? Is it the nicotine itself or the mixture of other toxins in cigarette smoke?
Well, I didn't say about vaporizers. I had said that patch has nicotine. Okay. I don't know what is in those vaporizers. I have no idea. So I can't mention, I don't know what is in the vaporizers. But I know that there are thousands of chemicals in that smoke that you inhale from tobacco that could be pro-inflammatory. But topical application of nicotine patch, I think, will be hopefully safer. Okay. But I don't know anything about vaporizers.
Okay, thank you.
You're welcome.
Good afternoon, Dr. Khan.
Good afternoon.
Thank you for your brilliant presentation. It's always very interesting to hear you because you present always in a very simple way complex issues, which I think is very interesting, and I would like to really congratulate the way you present issues related to the SpA.
Thank you, Marco.
Yes.
Marco is from Spain, and he knows exactly that it is afternoon because it's 30 seconds beyond 12 noon.
Okay.
So,
yes. So,
yeah.
Thank you so much.
Yeah.
And my question is about the disease progression and the role of the new therapies, because I have the opportunity to be with you in China and to see how people in China consider the disease, no? And they present the hips replacement as one of their solutions, no? And I was really surprised. And my question was in the difference between generations, no? When we look at people in my country, in Spain, and we see young generation where they are less disabled, they have less stiffness comparing to the oldest generations, and this is not something which is happening in China. And I argue, and this is my question, if it is due to ethnic or racial issues related to the biomarket, as you pointed, or if it is also related to the access to the new therapies, which may play a very important role on the decrease of the impairment and the disability across the time. So
hopefully my answer would be shorter than your question. So there are genetic differences, also epigenetic, environmental factors. Like south of the border, the disease picture is very different among the natives of that country, the Mexico or whatever that the ethnicity background. They get enthesitis in the feet after age 17, they develop spondylitis. Very different than the typical picture in Europeans or in developed countries. And there are genetic factors that are not yet known. So don't be surprised that the clinical pattern of the disease varies among various parts of the world. And one day we might be able to explain why the disease manifestations can be different in different ethnic groups, different parts of the world. It is yet to be scientifically studied. That's the best way to answer your question. Also, access to healthcare. Poor countries, the disease is worse. And maybe because their gut microbiome, they get Shigella, dysentery, other things, and poor no fridge at home, food poisoning, what goes on in developing parts of the world. For whatever reason, the disease is more severe in developing parts of the world than advanced nations in the world. That was very nicely documented when in France they studied the disease among people who live in North Africa versus those who are of North African descent but had been living in France for a couple of generations. The disease pattern was different, even though they were ethnically same population. So environmental factors definitely play a role. So that's called epigenetic factors and the genetic factors. So the disease is end result of genetic as well as epigenetic factors that play a role in final disease outcome. Well, thank you very much. I think unless there are more questions, Sean, you are the ones who
just one more question, yeah, and then we'll conclude.
Okay.
Dr. Khan, thank you, and I'll be brief. I read I'm not a scientist or a physician, but I've read in medical literature that there's a percentage of people that have AS and also have rheumatoid arthritis.
Yes.
Are those capable of being properly diagnosed? And would the treatment be different?
Yeah, I think very nice question. If the prevalence of ankylosing spondylitis roughly is 1% in this country, and the prevalence of rheumatoid arthritis is 0.6%, you can do mathematical calculation and you will be able to say what percent of the population could have both illnesses by chance alone. So the co-occurrence can happen, and when it does happen, when the peripheral joints are inflamed, these patients get readily diagnosed because their hands are affected, and x-rays can show changes, and also if a blood test is done, they will have more often rheumatoid factor, anti-CCP antibodies, other tests that help clinch the diagnosis of rheumatoid arthritis very early. And their spondylitis may not be recognized because the back pain may also be attributed to rheumatoid arthritis, although rheumatoid arthritis typically doesn't involve sacroiliac joints. So then later on, these patients show impaired mobility of the spine, x-rays show sacroiliitis, so then one can say definitely the patient has both rheumatoid arthritis and ankylosing spondylitis. Genetically, you can also say that rheumatoid arthritis has association with an HLA gene called HLA-DR4, and ankylosing spondylitis is associated with HLA-B27. So certain people in the world can have HLA-B27 and HLA-DR4. And if the environmental factors also play a role, then they may be more likely to get both diseases. So the co-occurrence of both diseases is well described, but is uncommon.
All right.
Thank
you,
you,
Dr. Khan. Stay right